everybody. Today we'll be showing you a video-based course on pearls and pitfalls in challenging capsular surgical scenarios. We have a very good faculty today, so I'll be covering on anterior capsular tears and flap motility sign and safe phacoemulsification techniques in presence of capsular tear. Capsular challenges in fibrotic cataracts, in posterior polar cataracts, in zonalopathies, Morgagnon cataracts will be dealt by Dr. Rohit Om Prakash. Capsular exfoliation and PCR prevention with IOL scaffold will be dealt by Dr. Supti Madholkar, and PCR during emulsification. Flax in intumescent cataracts and Morgagnon cataracts in posterior polar and zonalopathy will be again dealt by me. And techniques and scaffolds to prevent nucleus drop with sutureless fixation of IOL will be dealt by Dr. Ashwin Agarwal, and last by Dr. Cyrus Keki Mehta, bag IOL complex fixation. So coming to the Argentinian flag sign prevention and significance of flap motility sign in anterior capsular tears. As we all know, radial tears in the capsular excess margin are a common complication. They primarily occur during the capsular excess or can occur during any stage of nuclear emulsification. Majority of the tears are pre-equatorial in nature because of the anterior and equatorial zonules which act as a barrier and the thickened anterior capsule at mid-periphery. So there's a posterior equatorial extension which causes irrigating fluid in the anterior capsular pressure by lens material, which results into a posterior capsule rupture, a vitreous loss or nucleus drop. So anterior capsular tears, the predisposing factors are many like intumescent white cataracts, pseudo exfoliations, zonalopathy, shallow anterior chambers, pediatric cataracts, and fibrotic cataracts. Coming to the basic prevention strategy in an anterior capsular tear. So if the video is not playing. निकाल के दोबारा करना. एक सेकंड. अब तो चल रहा है. So if you see in this video, I'm trying to do capsular rexes, and now you can see it is going towards the periphery. So what I do here is I stop here, inject visco to make sure that the anterior chamber is properly inflated, deepen the anterior chamber, and when you have to bring back, remember the Little's maneuver. In that maneuver, what you have to do is you have to pull the anterior capsule 100 degree to the direction of the tear, and it should be the movement of the rexus forceps should be horizontal, not pulling. It should be horizontal towards the capsule area. This is another video. It is a case where the AC was shallow and there was increased posterior pressure. If you see here, I'm trying to do the rexus and it is extending towards the periphery. So what happened here is, what I did is, because the capsular rexus margin had gone towards the periphery, I made a nick on the opposite side of the rexus and tried completing it, as it had crossed beyond the iris margin. What is the strategy in white cataracts? So whenever you are trying to do rexes in a white cataract, always use a viscocohesive. Microforceps has an added advantage. So if you see here, the first nick that you have to give, what we do is we usually give a initial curved puncture because it gives a direction to the flap. So curved nick, and then make a small CCC, debulking by aspirating the fluid. This decreases the pressure, and then enlarging in the most deep bulk part, and thereby completing the rhexis. So nowadays, as described by Dr. Chi Soon Fik, we can do cortical milking also, which decreases the anterior pressure further in the peripheral part of the cortical matter. So this is another case where you can see that the anterior capsular tear extended beyond the equator, and what I did here wrong was I injected the visco in the line of tear and it extended further. What I should have done was I should have injected the visco on the opposite side of the flap so that it could lie flat on the capsule. So what should we do when you have an Argentinian flax sign? How do we manage such case? Can I have the audio? Audio G.
Case of white intumescent cataract with anterior chamber depth of 2.4 mm. I tried to carve out the rhexis and there was an Argentinian flax sign. What do we do now? I inflated the chamber with viscoelastics and regularized the capsular rhexis. I preferred chop technique with first chop done without much separational forces and not 90 degrees to the tear. At the same time, my focus was on trypan blue stained anterior capsular tear. It was fluttering and everted. Nuclear emulsification was done at iris plane. Fluttering flap meant 100% flap tear had not extended beyond equator. That gave me full confidence to continue the surgery with safe phacoemulsification technique. Had the flap become inverted and non-fluttering, it would have meant that the tear had become wraparound post-equatorial tear. There were minimal separational forces applied again. I also avoided sudden collapse or deepening of the chamber. My phaco parameters were on the lower side. Flap was still everted and fluttering. The initiation of rotational forces were minimal and were done keeping in mind that the rotational force did not put stress to the extended flap. Last nuclear piece was eaten and nuclear emulsification was completed with the continuous vigil on the everted nature of the flap. Cortical aspiration was done with lower vacuum with the fluttering of flap tear kept in my visual horizon. I confidently implanted the IOL in the bag as I knew the posterior capsule was intact because of the flap motility sign in my armamentarium. Flap motility For better explanation, these animations show that the pre-equatorial tear is everted and freely fluttering in nature. Hypothesis for fluttering flap is that the end point of the extension of the flap functions as the pivotal point for the flap. The flap, being short, is responsive to the fluid dynamics of the anterior chamber and thus flutters freely. But once the pre-equatorial flap extends beyond equator, the the flap becomes inverted and stops fluttering. As there is a breach in the barrier in the event of posterior extension of the extended anterior capsular tear, there is pulling down of the anterior capsule tear. The pulling down is because of the combination of the higher pressure of anterior segment, increased capsular bag volume, and the negative pressure of the posterior segment that pulls down the bag complex and makes the flap lie flat and eventually become inverted and non-responsive to fluid.
So this is a published sign now, flap motility sign of posterior capsular rupture and peripherally extended anterior capsular tear. So other challenges in capsular access challenges in zonalopathy are like there's a difficult initiation of the rexus, there's wrinkling, focal depression, halo sign, and there's mobility of the bag with tearing forces. So you can often use a cystitome to make the first initial nick and then continue the rexus. So any difference in the ACD in both the eyes preoperatively should give a suspicion of zonular dehiscence. Coming to the strategies in weak zonulopathy are, if you see in this case, so the second forceps is acting as artificial zonules, providing a counter traction to complete the rexus in cases of weak zonulopathy. This is another case where a case of weak zonulopathy, where when I'm trying to do rexus, with the help of capsular hooks, which act as artificial zonules, providing counter traction, thereby helping in completion of the rexus. Coming to the strategy in pediatric cataracts. So in pediatric cataracts, as we all know that the capsules are very elastic in nature. So always stain the capsule, which decreases the elasticity, use a viscocohesive, and do centripetal maneuvering of the capsule rexus. Try to make a small rexus in this, and you can see the rexus is completed. Thank you. Moving on to Dr. Rohit, where he'll be discussing the capsular challenges in posterior polar cataracts. Yeah, I don't need.
I think which practically everybody asks, which should be also clarified, that at what stage, suppose capsular rexus has been done, and there is an anterior capsular tear. The question is how to proceed now. Because the answer to that is, the first test is when you inject visco, if the flap moves or it becomes everted, that is the first sign that it is preequatorial. And if by any means, when you put in the phaco, with the fluidics also it will move. If it moves, this means it is preequatorial. If it doesn't, then it means it is postequatorial. You better convert. So that is one thing which I feel we should add to the whole scenario. So I would be talking about posterior polar cataracts with pre-existing posterior capsular defects. Well, the challenges in posterior polar cataracts are basically because of the fact that the PC rupture is there because there is a predisposition and we have whole lot of consequences involved in it. And there are situations around wherein the pre-existing posterior capsular defects are pre-existing in nature. So this PPC with pre-existing PC defects, the Daljit Singh sign is there. A defective capsule in the PC in the second eye is indicative that it can be a pre-existing defect. The earlier in life the patient presents with symptoms, the greater the likelihood for a defective capsule. Slit lamp examination is also obligatory and mandatory, wherein you will find that there are, particulate matters just behind the posterior capsule. OCT, I think we'll go into it in the next talk about the OCT findings to elucidate the pre-existing or the integrity of the posterior capsule in a posterior polar cataract. As far as the anesthesia is concerned, well, it's all surgeon's choice, what you are comfortable with. People like me at times mostly go in for topical anesthesia, but if you feel that there's a likelihood for a prolonged surgery, subtenuous infiltration can be also done. So let's go into things step by step. So this is a posterior polar cataract wherein you will find that there is a pre-existing defect. Now the first thing is the site of incision is very important. By any means, this site of incision should not be parallel to it. So there has to be an angle to it. The second most important part is the side port one. Because we need a stable chamber settings, by all means we do not want an undue efflux of fluid from the side port. So side port incision, the stepchild should also be taken care of. So side port calibration and site of incision relative to the axis of the posterior capsular tear is also very important. Next is the capsular axis. As far as the capsular axis is concerned, we need to have a small axis for some reasons and a large axis for some reason. So the way out is that you go around with an oval axis. Now this oval axis has quite a few advantages. Primarily, it gives the advantage of a large axis, all the features which a large axis has. There is no rise of intracapsular pressure. There is safe end-to-end sculpting. There is easy division, easy subincisional cortical removal, and smooth IOL implantation. As far as the small axis is concerned, optic capture, nucleus piece retention, and tamponading of the vitreous is there. Hydro procedures we have to decide. By any means, we do not want hydrodissection to be done. And wherein we cannot do hydrodelineation, then we can do no hydro procedure, phacoemulsification. So here the patient was young, there was hardly any nuclear sclerosis. So what was done was a step by step, layer by layer hydrodelineation. So in PPC, as I've already told, no hydrodissection, layer by layer is done. And in patients wherein the nuclear sclerosis is there, you can do cross-chopping with no hydrodissection and hydrodelineation. Coming to the next one, so let me explain how this case went on. Hydrodelineation was started. This hydrodelineation, you have to be careful. This has to be slow. Why it has to be slow? Because of the fact that at times we end up with the situation wherein we can have accidental hydrodissection and the whole thing can get undone. So what I am trying to do is what Dr. Vajpayee elucidated way back, that I am going to have layer by layer hydrodelineation. So you can find now 1, 2, 3 layers. So what we are going to have is we are going to have a cushion. We know that there's an open posterior capsule behind. So what I am trying to do is I am trying to take out the inner layer. So this inner layer is being taken out and you will find there's hardly any CDA being used. So it is only just phacoaspiration which is being done. So you can see now I'm just trying to reposition the inner core. Once that inner core is gone, next comes the core outer to it. So that is the peripheral layer. So you can reposition your phaco tip in such a way that you are able to aspirate from sideways, and you can always reposition these nuclear, soft nuclear layers or epi nuclear layers. You can see how I am doing it. CD you will still find it is 0, and IOP is 42. This was an old one. Once with all these outer layers done, I'm going to take out the outer layer. Still at this point of time, the open PC has still not been exposed. So I've taken care of the inferior one. Now I'm believing in doing stable chamber settings. I would like you to see what I'm doing now. What I'm doing now is, ideal situation when you have an open posterior capsule is that you should do a bimanual one. Why a bimanual one is done? Because of the fact that we want that there should be a different plane of irrigation and a different plane of aspiration. Here the trick which I have done is, I have retracted the sleeve. This retraction of sleeve is a compromise, no doubt. Having a bimanual is a much better one. But this is a way how we can have a biplanar with a coaxial one. So what I have done is I have retracted the sleeve. That is the first thing. And then my idea at this point of time is that by all means, I am not going to expose the posterior capsule. So what I'm going to do now is I'm going to use Epi Nucleus as a shield. So now what is this Epi Nucleus shield? I'm going to take it, I'm going to disengage it, and I'm going to dislodge it from its peripheral attachments, and I'm going to keep it there. I'm not going to aspirate it whatsoever. You will find that I'm dislodging it, and after dislodging it, I'm leaving it there. And then what I'm doing is, I'm just trying to take out the subincisional one. Mark my words, till this point of time, the open posterior capsule has not been exposed to any fluidics, direct fluidics whatsoever. So I'm using Epi Nucleus to my advantage by creating an Epi Nucleus shield. And now comes the last, no, this is the second last one, wherein I'm trying to dislodge the last lodged epinuclear cortical matter. So once that is, this is the last one which is coming, and here you will see that it has been done. So without exposing it, there's hardly any cortical matter which has gone behind. Now I'm just trying to inflate the chamber because I don't want any decompression. So now comes the trick in doing posterior capsular rhexis. It has already extended, but what I have seen in my experience that you can invariably create a round off capsular rhexis also. The first point is don't go through the main port, because by all means we do not want an unstable anterior chamber, because if by any means when you are using the capsular rhexis forceps, if the chamber is unstable, there can be a vitreous herniation and you can destroy the anterior hyaloid phase. So I'm using the side port, and with the microforceps I'm rounding off the capsular rhexis margin. So this capsule, I'm again inflating the chamber, and I'll complete the rhexis in a nice way. One part is already done. Then I'll go through the other side port, create another side port, and round off the capsular rhexis margin from the other side. So this part done, I have created a situation wherein the capsular rhexis is like this, and we have an elliptical one. The patient was young, and he had high expectations. So I am doing triamcinolone staining just to exclude or include the presence of vitreous, which was not there. I'll be implanting, and I could have implanted a single piece one in the bag, but I do, because the lifespan of the patient was more. So I'll take advantage at this stage of the oval rhexis and do an optic capture. The small rim would help me have an optic capture. So you will find now it is in place, one in the sulcus, and I'll replace it so that it goes, now it is fully in the sulcus, and I'm going to capture it. So this is what it is, how we can manage in an adult. These were the results in these patients. This is with a pre-existing defect in which the nuclear sclerosis was grade 2 to grade 3. Do I have 2 minutes for this? Yeah. So I'll just continue. You can see a linear, posterior capsular rent in that. So I'm going to create a valley. And once I create this valley, the next thing is it has to be end to end, so that I am able to create a situation wherein I divide it, and the division has to be complete. This complete division without marked separation, because I really do not want to put stress. Here comes the cross chopping. You do the cross chopping. So when you do the cross chopping, the nuclear fragments which are adjacent to the 6 o'clock one get eaten up, emulsified. So now you have a space created in this. Once that is done, you can see how I am taking it out. It's slow motion. You need not go fast. I am just moving it fast. You can see now this has been taken care of. Now I am trying to dislodge, and here you can see how I am managing it. By any means I am not rotating. I have not done any hydrodissection or hydrodelineation, because I'm somehow not comfortable in doing hydrodelineation in a patient who has nuclear sclerosis, and he happens to be in the elder age group. Now the last nuclear fragment or the epinuclear fragment is coming out. Sorry. So once that is done, so here it is. Now I'm doing with the dry irrigation, dry aspiration, and the IOL will get into place, a multi-piece IOL. Here it was an open posterior capsule with no rounding off, because that was not possible, and the case was duly completed. Thank you very much. So flax I will not be dealing in because of paucity of time. So basically this I'm not showing. So summarizing, we have to have a preoperative diagnosis, preoperative and intraoperative OCT. We have to have a specific technique. Not always are we able to complete it because there are times when we can have a nucleus drop. So we need to have a total VR backup. Dr. Cyrus would be presenting with the bag IOL complex management. It's good to see the new avatar of Cyrus. Yeah. I think he has really, COVID has been the best for him as far as.
Not financially though.
Not financially. Yeah.
So how many minutes do I have? 8, yes. Okay.
6 to 8.
So first of all, thanks very much, sir, for calling me, and thanks, Tushya, for having me in your course, which is a great success every year. So I've got some 4-5 videos. What we'll do is that we'll skip to the important ones and lose the others. All right. So I've been giving the subluxated lenses and loose zonules kind of course at ESCRS for many years now. And in a subluxated lens, should we use a ring segment or should we use an ASIA anchor? And when is each of them indicated? Classically, we've always been taught with the subluxated lens, use a CTR and put a ring segment because that is readily available. So let's have a look how the video went. Put the volume off, please.
Should we use capsule hooks or simply drop anchor when
All right, let's have a look at the first case. So in this case, we used a femto system, which we have the catalyst, in order that we get a perfect capsular excess. In a subluxated case like this with extreme subluxation, even though you may be a very skilled surgeon, now and then you're going to trip up and the rhexis will go to the periphery. But when you have access to technology, this is the real use of technology and not just to do grade 1 and grade 2 cataracts and sell technology to patients. So when you have a femto system like this, we must learn how to use it for cases like this. Use capsule hooks and then just put the ring segment in the eye after suturing it to a single tenoproline, which you railroad out of the eye. So railroading out of the eye is a very simple and straightforward procedure. A 26 or 27 number needle goes in the eye and then the proline goes out of it. And that's the ring segment. Inflate the bag, put a CTR and the IOL in the bag. Now that case is over. Let's go to the next case. What if you have a poor rhexis with a small rim of capsule? What options do we have in this case? Now this is the same femto laser which misfired, and instead of doing a capsular rhexis has done multiple punctures in the superficial cortex. So despite it looks like a rhexis, it isn't. It's some kind of cortical perforations. So I had to use a rhexis forceps, and sure enough, as I predicted, rhexis ran out. And I've pulled the rhexis back in by breaking a few zonules, which is not the ideal situation. So yes, we have a rhexis, but no, we don't have enough capsular rim in order to put capsule hooks. So you need a device like this called an ASIA anchor. This video was made 3 years back. And so this was ASIA anchor generation 1. There's a generation 2 now, which is 3-dimensional like a paper clip. So this is a 2-dimensional device. And once again, simple, just suture it to the proline and railroad the suture out of the eye. Then just use irrigation aspiration and suck out the cortex. So that's the anchor, and the trailing legs of the anchor will imbricate the capsular rim like that and hold it. Then pass the needle twice through half thickness of sclera. This will give you an opportunity to lock the suture and suture it and put the knot inside the edge of the tunnel. So it will not extrude out. So once you tie it tight, then you have a nice capsular bag And even this whole thing looks unstable, but it's really not. This patient is following up now 3.5 years. He's an 11-year-old boy. And so far everything seems to be good. So this was the end result of the case. Let's have a look at the next one. Can we use a single piece IOL as a CTR? This is what I showed 10 years ago and I thought it still has relevance, so I'm going to show it again. This is called the back to the wall technique, which we wrote up in Archives of Ophthalmology. So when you have an extreme subluxation like this, remember this was before the era of all this flanging and all this other stuff that you see today wasn't invented. And the only thing that people did in those days was a Sionis ring. Ike Ahmed hadn't popularized his Ahmed segment either. So this was far, far ago, many years ago when I was a lot younger. This was 2.8 millimeter phacoemulsification because none of the systems had 2.2 then. And that's why we had this big, huge Utrata forceps that people will laugh at today. But you have to make a nice small rhexis. So the cornerstone of success in all these procedures to use pressure, if you see the left hand is actually pushing the lens down, the iris depositor. So it gives you a little bit of counter pressure and turn the rhexis around. So if you got a bad rhexis or if it's gone very peripheral, then you had it and you'll have to end up with some kind of other procedure, but you won't be able to do this one. Make 2 openings, suspend the lens with iris hooks. If you have capsule hooks, it is better, but we didn't have capsule hooks, at least not in Mumbai 12 years ago. So all these things are there now. So this is like a blast from the past. This is the old infinity system that we used to have. But it does the job. Let's go ahead a little bit. In goes the CTR. Now that you have a CTR, this is a single piece IOL and you tie Prolene stitch right to the midpoint. So if you draw the line from where the stitch is, it should intersect the midpoint of the lens. Otherwise your lens will be decentered. Then you pass this needle down the barrel of the injector and pull it out. So this way you can use the same 2.8 tunnel and inject the lens inside, rather than having to do a scleral tunnel and use a PMMA lens. So now you have needle attached to suture, attached to leading haptic. In goes the needle. And then it should come out of the eye about 2 millimeters behind. Yeah, there was no railroading, you're perfectly right. So all these things are all after 2010. In those days, you just pass the suture anyhow. Inject the lens. So today we would do things a little bit differently to this. We'd probably railroad the suture out of the eye, but you can still use a single piece lens in this manner. We use a femto laser to do the rhexis. But in the olden days, without all the modern gadgets and modern toys and having to pay crores of rupees to the companies, you can still do a fairly decent job. Once again, pass the suture twice, tie it tight. So now your leading haptic of the lens is used like a CTR and sits inside the bag. But of course you need, remember there's 2 things here that you didn't really see clearly in the video. First of all, the needle passed through the fornix of the capsule. The needle did not go above the capsule like a ring segment would. And so that's why the haptic can act as a CTR and stabilize the capsular bag. If your needle passes over the capsule and comes out very superficially about 1.5 millimeters or just behind the iris, the lens will pop out of the capsular bag. So that's the only thing, take home message. So you can try this out if you're adventurous. So that's the end of my talk. Thank you very much for having me.
Thank you so much, Dr. Cyrus, for the such wonderful videos. Moving on to flax in different case scenarios. So I'm going to talk on flax in intumescent and Morgagnon cataracts, posterior polar cataracts, and zonalopathy. So literature has shown that femtosecond laser-assisted cataract surgery for white cataracts has no or posterior capsular tear occurred, whereas the risk factors for incomplete capsulotomy were seen in Morgagnon cataract and lens thickness. So the conclusion is the main complication of flax in white cataracts was incomplete capsulotomy, significantly associated with Morgagnon cataracts and increased lens thickness. Another study showed comparison with the conventional phacoemulsification. Flax for hard nuclear cataracts conserved phacoemulsification power, provided a significant reduction in corneal endothelial damage, and led to faster visual rehabilitation. So advantages in white cataract: it helps in fast completion of capsulotomy, which is within 1 second. It has an advantage of closed chamber. Then capsulotomy by flax, especially in fibrotic cataracts, makes it easier as it cuts the capsule over the fibrotic bands. You can see here, while doing flax, the anterior segment OCT shows fluid pockets with the black areas that you can see in the OCT. So usually when we do flax in white cataract, intumescent cataracts, the posterior capsular rexus margin is usually not seen. So we usually skip the lens fragmentation part. So this is a case where we did flax in a white intumescent cataract. The important points here is always stain the capsule, and when you're doing the rexus, because there are incomplete tags, do the rexus in a guided circular fashion. So I did direct chop in this case, and the phacoemulsification was completed. Coming to flax in posterior polar cataract, study by Dr. Mahipal Sachdev has shown how flax in PPC, especially the anterior segment OCT, helps in detecting the pre-existing posterior capsular dehiscence and increases the safety in the posterior polar cataracts. So what we usually do is we keep an offset of 800 to 1000 microns away from the posterior capsular rexus margin. There's another study by Dr. Vasavda showing a very nice femtodelineation way to enhance safety in posterior polar cataracts. So this is a case of posterior polar cataract where the anterior segment OCT showed dehiscence in the posterior capsule. So it helped us in preparing beforehand. So this is a case where rexus was done with the femto, and my technique here was stop and chop technique. The nucleus grading was NS2 as told by Dr. Rohit. No hydrodissection or hydrodelineation is done. Cross chopping was done. So nuclear fragment was divided and eaten. So slow motion phacoemulsification should be done, avoiding any nuclear rotation, low IOP, and as there was a pre-existing PCR, the nucleus was brought into the AC, preventing any extension in the PCR. Can you switch off the light, please? So before taking out the phaco probe, always inject viscoelastic in the AC so that there is no fluctuation in the interior chamber pressure. You can see the pre-existing PCR. IOL was injected into the bag as it had not extended. Then the hyaloid phase was intact and IOL was placed in the bag. So there should be no tapping of the lens, as it can lead to the extension of the PCR, and the case was completed. So coming to flax and zonalopathy, it was beautifully shown by Dr. Cyrus. So this was a case where preoperatively we could see that there was a gross difference in the ACD. It gave us an idea about zonalopathy. We did flax. So flax is a boon for zonalopathy as it helps in making capsular access very easy. So capsular access was done. Hydrodissection was done, slow hydro, and capsular hooks were used. The advantage of capsular hooks over iris hooks is as it goes up till the equator, providing a good support to the bag, acting as artificial zonules, and the case was easily done. So this is another case with a subluxated lens. Here, the advantage of flax in such cases is you can also customize your rexes according to the centration of the bag, and it makes very easy. Thank you. So I would like to call Dr. Trupti for her talk on PCR during emulsification and capsular exfoliations. Over to Dr.
This IC, I would be talking on PCR during phacoemulsification. For every cataract surgeon, happiness is to let the patient have an intact posterior capsule his entire life. So our happiness depends upon the intactness of this 4 micrometers or 4 microns posterior capsule. But most of the times the commonest complication which is encountered is a posterior capsular rupture, which may occur in 1 to 4% of the cases, but sometimes this incidence may be more. We should know what are the risk factors. Which cataracts are more prone to have a PCR during emulsification? So that we can anticipate the challenge, plan an intraoperative strategy and execute the plan. At the same time, we should have a backup plan in mind, like if a PCR occurs, what should be done. A thorough slit lamp examination and a thorough pre-op evaluation is of paramount importance. We have to see what is the type of cataract, whether it is a mature cataract, a intumescent cataract, if there is any zonular weakness or any phacodonosis, any fibrotic capsule, or if the cataract is of posterior polar type, or is there any pseudo exfoliation, if the pupillary size is proper, whether the pupil is dilating or not, is the patient a high myope, or if it is a vitrectomized eye, then the chances of PCR will be more. Same is the case if there is any history of trauma. So now we know what are the challenges related to the type of cataract. The other factors are if our visibility is hazy, or if the instrumentation is not proper, we have not adjusted the microscope, or if it is a very anxious patient. In spite of this, if a PCR occurs during phacoemulsification, how to go about it? Here we can see that it is a posterior polar cataract and an oval rexus has been fashioned out, and the emulsification has been started. At this point, here you can note that the PCR has been noted by the surgeon. It is a very scary situation for the surgeon because half of the nucleus is still there inside the bag, and the heartbeat starts increasing and we feel that this nucleus is going to drop down. So what should we do? The golden rule is just to stay calm and don't withdraw the phacoprobe from the eye. Just slightly manipulate. I have tried to manipulate the nucleus slightly at a superior plane, and without removing the phacoprobe out first, through the side port, we have injected viscoelastic substance so that the AC does not collapse. Now, if we want to phacoemulsify the remaining heminucleus, what can be done? Sometimes, many times as a surgeon, we feel that there should be something from inside which doesn't allow the nucleus to fall down. So what can come to the help? IOL scaffold is a very good technique for it. What is done here is that a 3-piece lens is implanted into the eye. The haptic of the 3-piece lens is placed over the iris. Now that the 3-piece lens or the scaffold is there in place, it is a very safe time now, so that we can do the emulsification of the nucleus, and this can be done at a slightly deeper plane also, protecting the endothelium. And using a low bottle height phaco, lower parameters, we can see that the chamber is stable and the phaco emulsification of the heminucleus was done. Here we have noted that the anterior hyaloid phase is intact when half of the heminucleus was still there in the eye and the PCR was noted. When we did the phaco emulsification with the scaffold in place, the vitreous phase was not disturbed. Rest of the cortical matter could be removed with using a dry aspiration, or you can use a eye cutter or a vitrectomy cutter with which you can remove. Ideally, we have to put triamcinolone acetate to find if there are any vitreous strands. This was not done in this case, but using a IOL scaffold, a PCR could be managed very well. The take-home message is that when PCR occurs during emulsification, using a IOL scaffold can provide a very safe technique. Thank you. Now the next I am going to talk about pseudo exfoliation, which is a very commonly encountered clinical situation. In a cataract list, we can see that most common or majority of the cataracts have some amount of pseudo exfoliation, at least in the Indian population. This is an age-related degenerative change wherein there is deposit of fibrillar material over the iris and the anterior segment of the eye. This fibril is deposited in the form of rings over the anterior capsule, and this is a classical 3-ring sign which is seen with a clear zone in between the 2 rings. What happens is, because of the deposition of this fibrillar material in the zonules start becoming fragile. And the various enzymatic action occurs over the zonules, and because of it there is fragmentation of the zonules and at the ciliary body, which leads to zonular weakness, or it can lead to a progressive zonulopathy. In the back, the forces which are acting are, the zonular force is a centrifugal force along with the haptic, and the anterior capsular rim is a centripetal force. When we are operating a case of pseudo exfoliation, we should know what are the predisposing factors for the weak zonules. Like each and every case of pseudo exfoliation will not have zonular weakness, but we should be able to anticipate. If the age is more, then chances of zonular weakness will be more. And the most important point to note is the ACD, or the anterior chamber depth. If there is a difference of anterior chamber depth in between the 2 eyes, or if the axial length is normal and the AC depth is less than 2.5, then always suspect that there is some zonulopathy in this eye. So there may be no phacodonesis, but when we start doing the capsulorhexis, we note that there is a zonular weakness. Denser the cataract, more chances of zonulopathy. At the same time, we can increase this zonulopathy also. A pupil size, noting the pupil size is also important. A smaller pupil size, a mid-dilated pupil, there is more chance of zonulopathy. What happens in pseudo exfoliation is, because of the weak zonules, you can see that the lens is moving anteriorly, the anterior chamber is shallow, and the pupil is mid-dilated. Here, this is a video in which we can see phacoemulsification is in progress. The pupil is well dilated, but while beginning the capsulotomy or beginning the rhexis, you could see that there were wrinkling of the capsule, so which indicates that there is some zonular weakness. The aim was to make a proper adequate sized at least 5.5 mm rhexis. The rhexis could be completed properly. A very gentle hydrodissection is done, and then the phacoemulsification is started. Here we have to note that all the maneuvers during nucleotomies should not increase the the zonular dehiscence. So slowly, and the forces should not act to increase the zonulopathy. When we want to remove the cortical matter, a tangential force is applied so that the zonular dehiscence or any does not increase. Here we have implanted a capsular tension ring because zonular weakness was noted. While implanting a capsular tension ring or a CTR ring, we start through the main port and slowly the CTR is dialed inside the bag. Once the CTR is in place, we can see that there is cortical matter which needs to be removed, and we can remove it slowly by using a tangential movement so that the zonules don't break. One more point which I would like to highlight for cases having pseudo exfoliation is the role of anterior capsular polishing. We have seen that most of the patients, when they come long term, they either have a dislocation of the capsular bag complex, or they have a contracted capsular anterior capsule or the capsular phimosis syndrome. We can prevent this by doing a proper polishing of the capsule by using curettes or diamond finishing. This will reduce the chances of capsular phimosis syndrome. So the issues which we need to deal with in pseudo exfoliation are the chances of PCR, nucleus drop, chances of corneal edema are more in the postoperative period. The IOP rise, secondary glaucomas also is there. There is prolonged AC reaction, and the long-term complications like capsular phimosis syndrome or late bag IOL complex dislocation can be there. Thank you for your attention.
Can you give us 5 minutes? Yeah. I would like to show a very interesting video on capsular access challenges and calcified subcapsular plaques. So, yeah. You know, these calcified subcapsular plaques, you know, you hardly come across them. But if you come across them, you really do not know what to do. Because when you're trying to create a rhexis, because of the calcified subcapsular plaque, that is most of the time Now it will come. I think till 3 years back, we were doing the same. But now what we have realized lately is that you have to identify these calcified subcapsular plaques. They are different than fibrotic ones. So in these calcified subcapsular plaques, there are adhesions in the subcapsular area. And these are calcified ones. So the plan is, so this calcified plaque, it is adherent in the paracentral or mid-peripheral area to the subcapsular area. So the plan is create a rhexis central to it, where there are no adhesions. Once you are able to create them, the next step should be, you should dissect it fully, so that you are able to separate them from the, anterior capsule. So for that we use different spatulas. Ultimately, with the one with the, femto, where we dissect in catalase, or for the, dissection of the anterior. Ho gaya? Abhi nikala nahi. So that is done, and then you go 360 degrees and separate it from the anterior capsule. And once it is separated, then you can just pull it out. And once that is pulled out, you have created a small rhexis. So that rhexis, now when there are no adhesions, then you can go with the scissors, enlarge it to the required size, and complete with the rhexis, and you are done with it. I think it's going to take 2, 3, 4. Why is it very slow? Heavy about? Should I show it as such? Because we are hardly 5 of us or 6 of us. Yeah, I'll bring it there. Central to the adhesion.
So you want to?
Yeah, I think it's okay. So now once this is done, so once you are done with it, then the next step is